4, 3, 2, 1. Good evening, everyone, and welcome to the 9th Conversations That Matter series in collaboration with the HSE. This evening's conversation will finish at about 10 minutes past 7, and during the course of the conversation, you are invited to put a question to the panel. If you complete the little question box at the end of your screen, my colleague Tina Joyce will collate your questions to Paul Connors, who will put your questions to the panel at the end of our conversation. My name is Caroline O'Regan. I work with the Institute of Leadership in the Royal College of Surgeons in Ireland. I am very pleased to have this opportunity to continue our discussions this evening around leadership in health and care in COVID-19 crisis. This is a particularly challenging time for leaders across our health and care services. I'm especially grateful and extremely delighted to welcome our panel of experts, our HSE leadership people, here with us this evening. I would like to warmly welcome the head of the HSE, Mr. Paul Reid, CEO. Hi, Paul. I would also like to welcome Mr. Paul Connors, National Director of Communications within the HSE, and especially like to welcome back Dr. Philip Crowley. Philip is the National Director for the Quality Improvement Teams within the HSE. Last Thursday, we heard from Anne Nally and Marie Ennis O'Connor from a patient perspective. They talked about some of the health practices that have changed and how the future is digital health technology focused, and why it is crucial to include patients and patients advocates in the design of future health systems. This evening, we want to focus on the leaders of the HSE and of our health services in Ireland, and how we can maintain good practice of leadership into the future. It's a good time to reflect on where we have come in the past 4 months. This month, last year, Paul Reid joined the HSE, and it's fair to say that Paul, his leadership team, have demonstrated sterling, courageous, calm and decisive leadership in what some might say was a leadership mission impossible. I would like to share a quote from Paul Reid on Twitter last week when he commented, "This day last year, I joined the HSE as CEO. I expected it would be tough, but never planned on a pandemic. I said then that I wanted to strengthen the public trust in the HSE. I think, and we think, it is fair to say that his leadership has enabled him realise that vision. This has been endorsed publicly, and public recognition and appreciation to the HSE leadership and the people of our health and care systems. In fact, last Friday on the Late Late Show, John Brennan, part of the Brennan Hotelier Group, and as a patient of the HSE, said, "In the last couple of weeks for the HSE, we have seen the very best and good that we, the public, can have ever seen. We have seen the human side of this association that we have never seen before." So this evening, we really look forward to hearing Paul's journey and Philip's journey and talking about their leadership challenges and their personal gains and lows, probably, it's fair to say, over the past 4 months. So over to Paul Connors. Paul and Philip, thank you so much again. We are extremely grateful for taking of your time this evening, and it's really lovely to see you. Thank you. Thank you, Paul.
Thanks very much, Caroline, and for those lovely words and introduction. And thank all of you who have joined us here to listen to us this evening and to hear, I suppose, the many challenges that we've faced over the last number of weeks. I'd like to thank the RCSI for organising this really important series of talks, conversations that matter, and I'm hoping that all of you who have joined those over the weeks have found them useful, as I hope you're going to find this particular talk tonight is going to be informative and useful. The format, plan 5 sections to this. I'll go through them in sequence, and I hope that we get time to get to each of them. We have a lot to get through. I've asked the speakers already to keep their answers very focused, and I'll be moving them on if that's not the case. And my plan is to bring both in at different times and to get different perspectives from both Paul as CEO and Philip then from the clinical point of view. At the end, as Caroline said, we'll have some questions from you. Clearly, we're not going to get to deal with all of the questions, but we'll take as many as we can. So look, I think in the interest of time, we'll move straight into the questions. And the first question I want to ask, I'm going to ask Paul and then I'm going to ask Philip. Both of you have dealt with crises, different types of crises and different scales of crises. Paul, is this the biggest crisis that you've had to deal with?
Thanks, Paul, and just say thanks to Caroline as well for opening comments, but and thanks too to the RCSI. I have great respect for the RCSI in terms of how they work with the HSE, but also for the support they've given me personally in my first year. I want to thank them for that. I think the straight answer to the question, Paul, is absolutely yes. But having said that, crisis seems to follow me throughout my career. I'm not sure if it's me or just where I go, but I have managed crises in different contexts. And I think the thing about crisis is when you're in it, and everything's relative. So it's not, you're not saying that when you're in that moment of crisis, it's not that one is bigger than the other. You have to deal with the situation you're in. So I've certainly dealt with crisis.
What makes this the biggest crisis? Like, what's the factor? What's the differentiation between this and others? Like, we know your role during the bust. You were Chief Operations Officer in Deeper, so you were in the heart of trouble at that stage. What makes this one different? What makes this bigger?
Yeah, I think the reality of it is you're dealing with people's lives and you're dealing with the impact and potential loss of life across a wide range of the public, and particularly the scary scenes we all saw across Europe and particularly in Italy. And we saw that, and I saw that, and I was scared. And I think our people, our staff were scared, and the public were scared. So you really went into this crisis knowing the potential impact of it. It wasn't that you were conceptualizing what might happen, which it can happen in a lot of crises, but you're dealing with people's lives and families being scared, and the responsibility that had, being a senior player in it that you had. That's what made it very different. The unknown, the uncertainty.
Philip, same question.
Yeah, well, I mean, it's hands down the biggest crisis I've ever encountered, confronted, or worked on. I mean, I worked in healthcare for, I can't remember how many years now, I wouldn't like to admit it, but certainly over 30. And really, there's nothing to compare to it. The intensity of the issues that we've had to deal with, the extraordinary way we've had to change how we deliver care, the terrible impact it's had on our society, the measures we've had to introduce to keep people safe, and then the fact that so many people have lost their lives. It's been harrowing and very, very difficult, but it's certainly nothing. I've never experienced anything like it in my life.
Okay. So, Paul, back to you then, and you've heard of the good elevator pitch. So, I want your elevator pitch. What have you achieved? So we're roughly about 11 weeks into this now. I think it was 27th of January or thereabouts when you convened the first HSE National Crisis Management Team meeting. So what's been achieved since that meeting? Elevator pitch.
Well, frankly, go back to what Caroline said in our introductions. I walked away from an interview last Thursday with Anya Longer at News at 1, and she just finished the interview and she said to me, thanks very much now, Mr. Reid, and all that said, but we know we all love our HSE. And I walked away from that and it was quite profound, the way she said it. She wasn't smiling, she seemed very genuine. And I subsequently bumped into her just later on that day, and I said to her, made a comment. She said, no, I really, really meant it. Now, so what that means for me is, from a public's perspective, I think we've connected stronger with the public. I think people have made a connection with the HSE, probably like they've never made before. And we can talk. I'm sure we can talk through the interview about why that might be, but I think we have. I know it's fragile. I know it can dissipate very quickly. I know things can change, but we should value where we are and understand why the public have a stronger connection now to HSE, I believe, than they had. And it was one big priority that I set out at the very start, genuinely. I wanted us to connect with the public. I wanted them to respect us.
So if we take, that's your biggest achievement, but it's been well articulated what hasn't been achieved. And I'm sure we've read a lot about this, we've heard a lot about this over the weeks. So let's just take nursing homes. Are you disappointed in relation to the fact that we didn't manage to achieve a better outcome for nursing homes? Is that something that concerns you at this stage?
Absolutely. And of course, I mean, we've all had family in long-term care and nursing homes, and I have, you know, from my mum for many years in a public nursing home, and my heart goes out to families. It really does. This is the one that gets me every night. It gets me every day about what could be done differently, or from a HSE perspective, from a wider state perspective. So you do have to think about, you know, the impact that this has had in nursing homes, the devastation that's, you know, had for many families.
Did we come in too late? Did you make decisions that didn't occur early enough? Is that something that is a factor?
I tell you what's on my mind a lot lately. I do think about, if you take nursing homes, long-term care settings, direct provision, and now meat plants. I think there is a bit for me to step back and think, did we create enough clarity along the way about who's responsible for what? And I'm not putting the responsibility anywhere else, but it just seemed to hover, and we all needed to run in. And I think, you know, one of my reflections will be about, and it is in crisis management, that you have absolute clarity who's responsible for what and ownership of it. And I think, you know, that's a personal reflection. You know, we may look back and we prove differently, but I think creating that clarity is really important. At our crisis management team, we had it within the HSE. You're responsible for that, you're responsible for that, you're responsible for that. But when you look at the wider kind of outside of HSE ownership, I think there were gaps around clarity of ownership.
Testing and tracing, we've heard a lot about that. Will it be on your tombstone, a series of broken promises?
Well, do you know what, actually, I kind of be careful how I say this one, because you can seem to be defensive. It's actually one I'm quite proud of what the HSE has achieved. And I look at what other countries have abandoned as part of it, and the UK abandoned their process and they're picking it up again. When you look at what we put together in 8 or 9 weeks, it was phenomenal. And I won't go through all the detail because it'll only waste time. But to put together an operation in 8 weeks, to now have tested over 6% of the population of the country, over 300,000, is absolutely phenomenal. And now in the last couple of weeks, all the automation that we're putting in place, and you've heard me describe it as a war zone model, to put that in place in 8 or 10 weeks, and to achieve what we have achieved, actually, I believe the nation should be quite proud of it. Now, we've had issues and we've been all over the place with backlogs for a period of time, and it did impact on public experience. But I think what we did was we stuck with it, we maintained it, and we're in the top tier of many countries in the world in our achievements and testing. So, you know, we've had it.
And that being said, the whole series of promises made early, not achieved as you went along. What would you say to that?
Oh, look, the reality of this, nobody was making promises. We were making commitments about what we felt was right at each stage of the journey, and we were striving to achieve them. A lot of them we achieved, some of them we hit the bar, and some of them we missed completely. And that is the nature of being in a crisis, you know. And I know the media and a lot of public attention need to put it in terms of you made a commitment, you made a promise, you know, you made a commitment, and you didn't achieve that. But I think on the round, when you look at our approach, the public's engagement with us, and the public outcomes in terms of the crisis so far, it's been quite significant. And that's not just a fluke. That's a consequence of a range of mobilisation, a range of public engagements, a range of passion that the public saw from the HSE, I believe, to do the right thing. So, you know, I think the outcomes are important, and the outcomes are really much better than we expected them to be at this stage.
Philip, over to you. From the clinical perspective, what do you think this most significant achievement has been over this past 10 weeks? Like, you've been monitoring this particularly from the quality assurance and safety point of view. Are you satisfied that sufficient quality assurance and safety has been achieved and everything has happened over the past 10 weeks?
I'm never satisfied. But yes, I mean, I think we've put in place a whole series of new services that I think have delivered a very high quality of care, achieving significant satisfaction from people who've been using them. New community assessment hubs, community testing centres, and I'd like to chime with Paul's comment about the contact tracing. I mean, many other countries abandoned that because it was too much, it was too hard to do. Too many people, if you look at what public health departments normally deal with and what they were being asked to deal with in relation to the numbers of positive cases and potential cases, it was a massive ramp up in demand on public health. So we put in place something completely novel. A lot of my QI team were involved in designing it. Of course, there were glitches. There were issues at times when we didn't have reagent, then there was a shortage of swabs. We were scouring the world for these materials, and our wonderful colleagues in procurement have really, I think, done the country proud in many ways, because we managed to get it back on track and most importantly, I think, align the tracing and testing regime with the demand, because when that's out of kilter, obviously then you get delays, and none of us are happy with that. But yeah, I'm very reassured that the services that we put in place have been very well thought out. A lot of clinical leadership demonstrated in developing them, and I think they've been safe and they've done their job. We've got people tested, we've got people assessed in community hubs, and we've managed to free up general practice then to get on with the regular work of general practice and make people feel comfortable and confident to go and see their GP, which is so important.
What was your biggest concern from a clinical perspective in all of this when we started to scale up? What was your biggest clinical concern in the back of your head? What kept you awake at night?
I mean, firstly, that the health service would be just overwhelmed. It seems to be seen in Italy. Contact we had with people in Italy was quite frankly frightening. People making decisions about prioritization of care that we've never had to make, and we didn't in the end have to make here either. That's what really worried me. And now I'm worried. I'm always worried. Now I'm worried that we need to re-establish some of the care that we've had to pause and make sure that people aren't harmed from other diseases as well. But we have to get that balance between the two strands of work that we have to cover, and make sure that we don't end up in a situation where our services are overwhelmed and we have to make unacceptable choices. That's what kept me awake.
Let's go back to January 27th, Paul. And if you were doing it all over again, would you make different decisions on anything? Would you do anything differently?
Oh, I think you'd always have to stand back and say you would. And I think, by the way, there's still a bit more learning to go on this, and I know it's a conversation that we're having. There's a danger that we all think we're looking back so far, and I said this to the Doctors Committee the other day. We're not. We're still in the middle, and we're trying to look forward, and we're not too sure how we look forward either. So it's important that we just kind of reinforce that. And so yes, there's been learnings, and yes, I have personal reflections about what you might do differently. I will come back briefly to the point I made, which is the kind of healthcare beyond the responsibility of the HSE. I think there is a bit about collectively us all thinking about who is going to take ownership for what at what point in time. And I say that between, what we're seeing in direct provision centres at the moment. You have the Department of Justice, you have ourselves, you have the department, and they're calling out to us. And we're, equally there's a responsibility. I just used that as an example. There's a responsibility of the managers of direct provision centres. There's a responsibility of the management of meat plants, and there's a responsibility of the management of private nursing homes. So I think earlier on, I think we should have made sure of that ownership and the interfaces, Again, early to make the complete judgment about it. It's one I'm thinking about a lot at the moment.
Okay. So I want to move on to another section, which is probably of interest to lots of people who came on here, because this is leadership and it's a leadership seminar. Let's stick with you, Paul. I'm sure you were asked this question for your interview or interviews going for this role. What is your leadership style? Do you have a leadership style?
Yeah, and I think the way I always try to look at this one is take the feedback that I get. So throughout my career, I've always valued we've all done 360 feedback, and I do it, and I've kept a mentor with me all my life, all my professional career, certainly for the last 20 years, who's a professional.
You would like to name the mentor here, would you?
Yeah, no problem, actually. Yeah. I can do that later. But it's somebody, and it's a great process for me, because you just, you can just stand back and take direction, and they can evaluate your feedback better than you can. But anyway, I think what's been my experience, what people have said back to me is, I think as a style, I would say people would say probably firm but fair. One of the best experiences I had with my first line manager in my career, I was a technician in aircom, and we had a equivalent of a team leader at that stage. And I always remember their style, and I valued it then, and I still value it now, which was, really challenging within the organisation, but really defending the organisation. You know what I mean? Your public view has to be you're on the side of the organisation. And I learned that so early, and I try to keep it with me, that within the organisation, challenge everything you do and set the bar high for everybody and for yourself. But when you're out, you don't let the guard down. And people talk about Alex Ferguson. I'm a Leeds United fan, by the way. I'm not a Manchester United fan. But Alex Ferguson was kind of recognised as that. He would defend the team ultimately outside, but with inside they would challenge what has to be challenged, and that's something I value. People will judge whether that's what they see.
Is there, so you've laid out what your leadership style is. Do you think that it's possible to have two leadership styles, one for, let's call it, peacetime, and one for wartime? So in other words, I suppose my question is, do you have a different leadership style, or do you carry your leadership style from peacetime into this COVID type of situation?
Well, I think the reality of whatever your underlying values are will carry through, and you'll see them. Your behaviours might change in different scenarios. So when you're under a different environment, like we have been for the last 2 weeks, people may experience some different behaviours, but I think your underlying values will be the same. Specifically, Paul, to answer your question, certainly if I look at my first 9 months, it was a lot of kind of trying, I'd say 60-70% of my personal commitment was outside stakeholder management, trying to create a vision, trying to create a focus for the board, trying to get government on board, trying to get the department working with us, trying to get key unions. When you're in a crisis, actually you have to kind of revert to mobilising the organisation. So I probably found myself, you do have to kind of connect stronger with all the key processes and driving the organisation strong to mobilise for now. You still have to balance that with the external bit, but I certainly found in a crisis, you do have to not cross over everybody's role, but you do have to create the pace and the energy and speed and the leadership that's needed for that.
Philip, can I move to touch on somebody who Caroline mentioned earlier, who's speaking to this group next week, Michael West. And I thought you'll be familiar with his leadership model of compassionate and collaborative leadership. And I suppose his big thing is where you shift from directive to collaborative, where you encourage innovation. Do you think his style of leadership is possible during this type of a very intense crisis?
It's a very good question, and I'd just like to chime in with what Paul has said. I think Paul's leadership he's described it very well. I think you can show direction, be decisive, set standards, but you can also defer to expertise, which I think has really happened during this crisis. I think you can defer to frontline knowledge, which has definitely happened in this crisis. So I think you can have two different kind of leadership, not necessarily styles, but leadership movements, if you like, happening at the same time. They're not exclusive. At times, centrally, you've got to make decisions. You've got to make them quickly. You'll make mistakes. We've become much more comfortable with mistakes, which I think is good, because we'd never make a decision otherwise if we couldn't make some mistakes. But I think they can coincide, and I think they need to coincide, because if it was just all command and control, this is my way or the highway kind of thing, it works for a while, but you lose the team. So I think we haven't lost the team here, and I think equally you can retain a decisive core to your leadership, and yet allow people to innovate at the front line, act on their own ideas, which is collective leadership, and that's certainly something that's core to the strategic approach to improving quality that our team have been sharing with the organisation prior to this pandemic.
So in very, very few amount of words, Paul, would you agree with that concept of being less directive and more collaborative in this sort of intense COVID type situation? And is it something that not alone is possible, but that we're doing? Do you agree with that?
Yeah, I have to say one of the things which has been very inspiring for me, very briefly, is how we seem to unlock the organisation. People just felt empowered, and I've picked that up from every level, from the services and from the centre, where people just said they felt they could just get on with it and make quick decisions, and felt empowered is a very flowery word. What it means in reality is people can get on with it. They did things, they were innovative. So I think you have to. I think we did. I think we need to give direction, we need to give focus, and we give priorities. But after that, let people do it, and I think in a crisis, and I think the learning for us in a crisis is, how do we do it now in peacetime, as you've described it, Paul?
Okay, so I'm just going to look at 4, and in the time that we have, and I need to move on to the next section, but just to close out this leadership part of this discussion briefly, I'm going to look at 4 elements of leadership, and I'm going just to kick them over and back. Just briefly give me your views on this. So organizational culture, is that something that's important to you, Paul?
It is, but I think we need to, from the HSE's perspective, it's a big organisation and there's not one single culture. So I think we need to be careful about, I think what is important are the values, what people drive, and I think there's been some great work done in the HSE and that, but there's not one single culture, and it's not just a professional, different professions, it's different settings, it's acute settings, it's community settings, it's social care, it's vulnerable groups, different cultures, and we should respect different cultures in the organisation. So my certain learning of the HSE in the first year has been to value actually very different cultures that are around the place. Have some kind of common teams that people can have a hook and hang on to and know what the organisation is about. But be careful that we don't try clone a culture now where it doesn't fit. Would be my.
And so Paul has mentioned values. Philip, I'll pass this one over to you then. In terms of what you've seen, the value set that we have, will we have to change the values in wartime? So in other words, have we a different value set in wartime than we have in peacetime?
Where did you come up with these questions, Paul? Goodness me. Absolutely not. That's exactly what you need in a crisis when there's, a lot of noise, a lot of pressure, a lot of issues arising. It's the values that see you through. You hang on to your values, your leadership will survive the test of the crisis. And I completely agree with Paul in relation to that. I think if your values aren't evident in your behaviour, we may espouse values, but if it's not evident in our behaviour, then there's a serious mismatch there. And I think I do believe that we have hung on to our values during this crisis, maybe even strengthened them. And I don't mean just some set of values, but the real core things that drive us. What will this mean for patients? How will this affect people in our society? That's all that's important. And I think I think values. If your values start to shift during a crisis, then I think you're in trouble.
Very good. Quickly then, Paul, balancing the short-term objectives versus the long-term objectives. So we're in the middle of a crisis. We've got a whole series of short-term things we've got to do rapidly to save lives versus those longer-term objectives. How do you balance that?
Yeah, well, the first thing is to say the longer term objective is to save people's lives as well, so that will hold true. But I think we had a good discussion with our board about this as well, because what we need to understand is what have we done here for the short term that actually is strategically right for the long term. And I think what we've managed to learn in a very short space in time is our frontline teams, people who work in services, know what's the right thing to do, and they know what works. And if you can manage to unlock them to do it, it can have a powerful impact. So certainly for me is the learning for this short-term firefighting phase that we've been in is how do we now in the long term actually sustain that kind of culture, sustain that kind of environment that we now just can actually unlock the organisation better for the future and let them design the solutions and let them implement it. So short-term, long-term, for me, the big priorities for us in the future are about sustaining that public trust, are about revising our services in a very different way, are about integrating the acute and the community stuff. What did we do during this war zone time? The acutes and the community worked better than they've ever worked in before, you know? So there are short-term stuff learnings that are now going to inform us better about the long term, you know, ironically enough.
And we'll come to a little more of that on the closeout. Philip, so lots of changes, lots of significant changes in a very short space of time. Obviously, people will put on the green jersey and do their best. But if you meet resistance to people, by people at that juncture, how do you overcome that as a leader?
Well, I think you sometimes you bypass resistance, to be quite honest. But clearly, our job is to try to win people over, to have a convincing vision, to have some data to show that if we do X, Y, or Z, it's going to have the desired impact, and to show us the common good that we're trying to achieve, the good for the patients and the public. And that can overcome an awful lot of resistance. And if that doesn't overcome it, then you need to start going around it, because you know, I think the other thing actually that Paul was talking to there, you know, about not going back. An awful lot of people are saying that. There is always a risk when you come through a fairly cathartic experience, both personally and as an organisation and as a society, that you almost want to revert back to the old way of doing things. I don't think nobody I'm speaking to has an appetite to go back to, you know, the way it always was. Precisely what Paul's been saying there around kind of trusting people's expertise, trusting frontline staff who know, the porters know about the front of the house, the security staff know about how patients react in certain situations in the front of a hospital. You know, our staff are experts in their field, so let's keep listening to them. So, but in relation to resistance, you obviously try to mount a reasonable and convincing argument, and try and understand where the resistance is coming from, and then frankly bypass it if it's unsurmountable.
So a similar type of topic to that, Paul, and I'll come to you, and then we'll move off leadership. So staff are going through a very difficult time. So they're working long hours. They're working in environments where there's considerable risk. There's considerable risk for them to bring COVID back to their families. There is a certain amount of burnout coming through from winter straight into COVID. There are longer term issues around pay and conditions. How do you keep staff motivated? How do you actually get them to give the best that they have been doing while dealing with all of these issues in the background?
I think there's two things. One is be relentlessly honest and truthful with staff. You know, so things like paying conditions, which you've just said, Paul, will be real issues, have been real issues, will be real issues as we go forward as well. Be absolutely clear and don't make false promises. You know, that's number one, and take the tough issues and be honest with people and staff. The second one I would say is being relentlessly publicly reinforcing what's happening inside. I learned one lesson early in my career from the French chairman of ERCOM, and he said the best way to communicate with your staff, one of the best ways of supporting your staff, is keep talking about them publicly. You know, and that's something I've been trying to do quite a bit, is publicly talk positively about people, HSE, our staff, our teams, what we do, the commitment that we have. So I think there's two things. We need to give people consistent reinforcement, and we need to stay honest and be truthful. You know, what we're doing well, what needs to change, you know, and that's my role as a leader of the organisation, to be relentlessly truthful, you know.
Okay, so just to move out of the leadership and in the time that we have, I just want to touch personally for both of you. And I see you're looking at the clock there, Philip. It's flying by, believe me. So, Paul, stick with you. Just tell the guys who have joined us tonight, what does your average week look like? during COVID, I mean, no, not generally.
Yeah. It's probably during COVID and pre-COVID. You mentioned 26th of January, Paul, when we convened the first National Crisis Management Team, and it's been relentless for everybody in the organisation. So it's not about me, but certainly the average week it's Monday to Sunday every week. I mean, I certainly wake up in the mornings now and I don't have an idea what day it is. Sometimes it's Sunday and it's Wednesday. Sorry, it's really Wednesday, but I think it's Sunday and vice versa. So the week is just relentless at the moment. You know, and it's we have a press conference on Sunday, Paul, that you lead with us. You know, I spend most of my Saturday preparing for that, because it's literally an exam every Sunday. You have to be there, you're a public face, it's live. You have to be on top of your game. So a lot of my Saturday is spent preparing for Sunday. You know, so it's a relentless week and nothing is planned. Whatever today's issue blows up into can dominate the day, you know. So, but there's certain points that I look forward to, and I give myself my little treats during the week at a personal level, which is sustains me.
Do you want to describe what those treats are?
Oh yeah. Well, there's a couple of them. I suppose one is obviously for everybody is family. You know, I've a great family and a great support around me, which is great. So I need to make sure that I create space and time for them, and I value that hugely. So yeah, we even if it's sitting down for dinner and just making it a special treat, like everybody's doing at home at the minute. But that's nice. And then, you know, sorry, very briefly, I have a granddaughter, as some people will know after watching me on Twitter, in States, and I must say, you know, a 15-minute FaceTime call for me some night at random, it gives me a week of energy. It just does. And then finally, I'll share a little one, which is I used to always enjoy a few drinks. Well, sorry, I should say a few glasses. I used to always enjoy a few drinks on a Friday evening with friends of mine down in Leitrim, and that can't happen anymore. But I made a special effort at the start of this that we still have, like many people do, 9:30 on the Friday night. We have about an hour and a half together, all the friends who we would have met, and we just chat with a glass of wine beside us, whatever we do. And you know what? I look forward to that during the week. No matter where I am, I'll make sure that happens. And so, look, like everybody else is struggling at the moment. Yeah. That's nice.
Philip, how do you? And I know you're
characterized it. When I was in college, one of my mantras was every night is Saturday night, which was the approach I had at that time. And I've sadly come to the stage where every morning is now Monday morning. So it's no more than anybody else. I'm not looking for an ounce of sympathy. I'm very lucky to have a job. I'm really delighted to be centrally involved in trying to help deal with this situation. And I think Paul does too. I mean, I use exercise a lot just to kind of keep myself together mentally and physically. Just if I can get in a bit of exercise at some stage of the day, morning or night, and then, you know, we've some nice Zoom interactions as well with people, or house party, or any of these new things that I never knew existed before this.
Very good. So I'm going to move on to the last section here, which is a very short one, and then I'm going to bring in some questions, and we're pretty close to getting towards 7:15. So we've touched on a couple of these already. In other words, what we've learned and but I suppose the question, just to re-emphasize point that you've made in the introduction here, Paul, which is, what have we learned that we can bring to the services going forward? I think that's a question that lots of people tonight would like to hear.
Yeah, I think a couple of things. One is the I think if you look this from a public's perspective, what did the public experience and what they experienced so far? I think the public have experienced a more unified health service, and that's not just about the HSE. So the GPs that we've had working with us very closely, our own consultants and clinical profession that we have working with us very closely. The public experienced a more unified health service. You know, there's been a lot of brilliant spokespersons out there from GPs, from our consultants, and that means a difference. That's not people all having a pop off to HSB, and many people have and will continue to have, and that's fine. But in general, the public have experienced a more unified healthcare system, and I think that's powerful.
But would you see, let's say we spend a lot of time and effort and see the value of, let's say, community assessment hubs. Would you see a role for community assessment hubs post-COVID?
Oh yeah, if you look at the services, there's 2 or 3 things that jump out. Well, I would say no-brainers for the future. We've always had primary care centres, but the problem is we didn't have all the skills in them. So GPs, now that we have a very new and strong relationship with our GPs, I would love to see more GPs in our primary care centres and make them a very different experience for people, a very different footfall. If you look at our community assessment hubs that we have in place, they were driven largely to for COVID services, right? So that GPs come back to their practice. But there's been learning in the community assessment hubs as well from GPs. Again, so some of those learnings, they mightn't be COVID hubs in the future, but they're a new way of keeping people out of the hospitals. I think if we make a big commitment, just look at the big commitment we made at the start. We can't have our hospitals over 100%. In fact, in the future, we can only have them at 80%. That's a big commitment. And when you make that commitment,
that's a big statement, but like, does that require you holding on to the private hospitals? And that's a question that we have heard a lot from media over the last number of weeks. So it's great to say that we can't have over 80% capacity, but how do you achieve that without the private hospital capacity?
And this will be a big discussion with our board, the HSE board. It'll be a big discussion with government, because number one, while COVID is with us, this is not a choice. We can't actually let it happen. Public will not expect us to bring people back for their services and cause an outbreak in a hospital. So bringing people back for services that might not be critical services and then an outbreak, and you have caused an outbreak of COVID in a location. So you have to walk back from it and say, how will that be different than what will be needed? For me, to speak frankly, I think the private hospital system has to become more a part of the overall health system. That doesn't mean it has to be made public. It means it has to be an integrated part of a total healthcare system. And we have to have an agile environment for the future that will involve calling on the private healthcare system as required for the future, for whatever needs we may have in the future. That's my view as CEO. That's what I will be projecting forward. An integrated system. I always believe there will continue to be private and public. People will make their minds up on that because 50% of people subscribe to private care. But we should value both, and we should look at how we integrate both, you know, in a very different way for the future.
Have we just put Sláinte Care under a microscope, do you think?
No, look, the reality of what's happened in the last 10 weeks, which is very positive, we've put a lot of what some of the commitments were in Sláinte Care into practice. And everybody will want to sustain and retain some of that. I've said this very publicly. When we look forward now, like everything else, we should look through a new lens and see what was mapped out, what have we proved, and what should we test again. Now, they're a big decision for policymakers, and ultimately won't be my decision. But I will be looking through a new lens, and I will be informing that decision to say, actually, when you look at what's happened, maybe this is the priority and not that thing that we were going to do. So it puts everything in a microscope, puts the healthcare system in a different lens.
Philip, I'm going to close out in this section and I'll come to a few questions then, unless Caroline sends in her shepherd's crook to pull us all off here. But just in relation to vulnerable people, and I know you in your professional capacity, you deal with a lot of vulnerable people. Do you see what the changes that have taken place over the last 10 weeks as being positive towards how we deal with vulnerable people? And do you see that with learnings that we can take into the future around vulnerable people, particularly the homeless?
Yeah, well, that's a very important question. And, I would say that the mortality rate amongst the homeless population fell in the last month in comparison to the same month last year. It was lower than it was last year. Why is that? First of all, we protected them from the virus fairly effectively. We cocooned people early on who had either chronic obstructive pulmonary disease or other serious risk factors, and we identified, tested and isolated people very, very quickly. We also tried to put people into better accommodation. So let's be honest, the HSE is not responsible for all of social policy, and the virus has certainly exposed weaknesses in our society in relation to how we deal with vulnerable groups. Low-paid workers living in greatly overcrowded settings, very, very vulnerable to outbreaks of this disease. So now that the lens is being cast on this, I think as a society we have some choices to make as to whether we want to sustain some of those gains. We've freed up access to methadone, for example, so people who were dying of heroin overdoses are now in huge numbers now on methadone and stable and safe. So I think we've done a lot of good things, but I certainly don't want to go back.
Excellent. Caroline, have we got 5 minutes for questions?
Yes, absolutely, Paul. Please keep going. That's great.
Okay,
Thank you.
very good.
Paul, can I just make one? Paul, can I just make one quick comment? Because I wanted to see whatever questions come in from the people who are registered. But I think there's always a risk in this kind, for me, in this kind of engagement that we or I am portraying. We've been in the middle of this, and look how great it is, and we all are. My mind is more on. When I go, a lot of people say to me, "Oh God, it must be very tough. It's relentless." And I actually feel one of the lucky ones, because we're all getting up in the morning, we're all going to work, we're all busy, we're all active, we're all doing what we're doing. Everybody knows I come from a pretty working class family. I have brothers, sisters, family, nephews, nieces at home, worried. Are they going to lose their job? Will their job ever open again? I have a daughter working in childcare. She doesn't know when she'll ever get back. So there's a lot of people out there, I genuinely mean it. I feel one of the lucky ones, and it's people who are stressed and uncertain. And I think we need to think of that as public servants and as civil servants. We're making big decisions. We're making big recommendations. But there's another aspect to all of this, which is just the mental resilience of people out there that it's being tested at the moment. And I just want to make that comment because there's a risk of me portraying, look how hard it is, look how great we all are.
Yeah.
There's people suffering here.
Yeah.
No, it's a very fair point. Okay, so listen, just a few questions. We have questions and comments that have come in. The comments have been, and thank you for the people who sent these in, talking about Paul and Philip. Paul and Philip, two great leaders, two exceptional leaders, a lot of that coming in. Question for you, Paul, it probably leads or flows from Caroline's introduction. If you had a crystal ball and could foresee the pandemic, would you have still taken the role as CEO?
But it's really interesting, and I won't stay too long. The interesting thing about being in a pandemic is everything's clear, everything's focused, all the priorities are geared towards this. I don't mean this flippantly, but it's nearly easier than all of the wild things that happen in health every day of the week. So I don't mean that flippantly, but in a pandemic, actually, you get everybody galvanized and everybody's mobilized, and there's one big priority. We need to manage all the other priorities now as well. But no, I would have taken it very briefly. I love this job. I really do. I passionately love it. I never feel stressed. Well, I never feel hate going into work. I love it. And people said I was mad at the start, and that's not the truth. It's very privileged role.
Very good. I'll ask this to you as well, because it probably wouldn't be right with this to Philip, but what role have the clinical leaders played in this pandemic? And maybe you might just talk about the engagement as well, because there's been a lot of that. That's for you, Paul. Sorry.
Oh, apologies, that was Philip. Yeah, I touched on it earlier on, and people would have heard me saying earlier in my first year that I wanted to connect stronger with the clinical profession and value what they do, and they've done it in spades throughout this process. The leadership they've shown, not just publicly, internally, the organisation they put behind this, the thought process they put behind it, their professionalism, their planning, has just been outstanding. So, I think we've some of the best clinical professions we should be really proud of. So I want to thank them. Many of them, some of them might be on the call, many of them I'm sure, but it makes me really proud what they've achieved. And we need to think now about how we keep that, sustain that kind of, not just relationship, but process and engagement. And Dr. Colm Henry, our Chief Clinical Officer, obviously isn't here tonight, but I want to thank him and indeed Philip as well, who've managed that engagement process and stuck with it every week during this pandemic. And it's been hugely valuable.
So whoever sent in that question clearly created a platform for the next question. And I'll put this to you as well, Paul. Should more senior positions be filled by clinicians after this?
More senior positions, is that what you said?
Yes, more senior positions be filled by clinicians after this.
Yeah, and Colm knows this. I've said this to Colm relentlessly. We need to kind of build a process and build a culture and valuing people and putting people in prominent positions. I'm not a clinician. I need that support around me, and I rely on Colm and Philip hugely. So more of that is what the organisation needs.
Philip, one for you here. Will we see more telemedicine and changes in service delivery through telemedicine?
Well, I sincerely hope so. I mean, I remember prior to the pandemic, we had a virtual orthopedic clinic in Tullamore, which we thought was running really, really well. And we were kind of looking at it and maybe evaluating it. But along comes the pandemic, and we just mass go into new ways of delivering care. I don't think telemedicine is a panacea. I think, for first interaction, sometimes you need to eyeball people, clinically assess them properly, but certainly an awful lot of care can be delivered more effectively. And I know, at least anecdotally, and it's something I think we need to look at, is to maybe survey patients to see how they've experienced this care during the pandemic. And I think we might examine how we might do that. But certainly from anecdote, some people have really loved the idea that they're not sitting around waiting for hours in an outpatients. That the consultant rang them, checked them out over the phone, gave them advice, and they were extremely happy. So yeah, I mean, we will see more telemedicine for sure, but it has its role, and it's not for every consultation.
Clearly, a lot of our audience, people who have logged on to look at this evening, are clinicians. So question in, I'll give this one to you, Paul, and Philip, you can chime in as well. What advice can you give, excuse me, can you give clinicians who are not in leadership positions, and how can we help? So in other words, I think what they're asking here, those who are not in leadership positions and who want to be part of decision making, how they can become involved in decision making.
Yeah, and I must say it's one thing that struck me in my early days in this role was that there seemed to be a kind of parallel set of streams. There was a kind of management of hospitals, let's say, for example, and administration and nursing, and then there was the clinical. And in some places you could see it really well integrated, but in a lot of places you saw it as two parallel streams. And I think a lot of the solution to that, a lot of it will be how we organise ourselves in the HSE, and everybody knows I've been at the start of this process looking at the centre of the HSE and how we get closer to the services. And one thing is demonstrated, when we do it, it's much better, as in the pandemic. So there is a piece now about us, what can clinicians do? I think just, and I mean this genuinely, putting themselves forward into the management decision making of a hospital. And I'm not being critical that they haven't, but we need to facilitate that. When I met a group of consultants regularly with Colm Henry before this process, they relayed to me that they felt separate to, not connected with when I was trying to manage funding and finances. They felt removed and not part of it. So there's a bit for us to facilitate that to happen. But equally outside is a challenge I'd put to consultants and clinicians as well, to put themselves forward into that management decision making. Doesn't always have to be at the top level either, you know.
Yeah, just to add to that, I mean, chiming with that, and I mean, obviously some of the things we can do is we do offer the whole series of different training programs that we offer people to try. We with Caroline and colleagues in the College of Surgeons, we offer clinical director training programs, which we fund and are highly sought after and very successful. There's the Leadership Academy. There's our QI training that we do both with the College of Physicians and on our own QI training. So there's a whole load of training opportunities that I think help people just look at the world in a slightly different way and open up their minds to doing things differently, and that's leadership. And as Paul says, you don't have to work in here in Dr. Stevens to be a leader. We need leadership at all levels. We need teamwork at all levels. So I'd encourage people to avail of any training, get in contact with us, and but exercise your leadership, practice it in your own area with your own team, build your team, and that'll create a much better health service.
Paul, can I just make a very quick comment on it, because I think that's an absolutely brilliant question, and if that's what people are thinking, we need to think about it really strongly, and it struck me. But I just give you a personal reflection. I've managed in all different sectors now. So private sector, a long time with Aircom. I managed 7,000 engineers. I've never been an engineer. In the Tropra, which is a fabulous year and a half for me all over the world. Never in the not-for-profit sector. Valued it hugely. Central government, local government here. And my kind of leadership experience has been, step away from the detail of the design of the organisation or the skills of the organisation, the profession of the organisation. It is what Philip has been talking about. It is about that space of what gets people in, what fires people up, how do you get into their hearts and minds? Not just for what gets the fire in the belly of people. What's the emotion that really connects with people? Yeah. And you value the clinical skill. You connect with people differently, has been my experience.
Yeah. And I think that kind of the next question, which is directed at myself, how can we continue to nurture positive culture, maintain pride and motivation? And I think what you both have just said there is pretty much at the heart of that. And it comes back to a single word, which is purpose. And I think it's all about purpose. And I think our purpose can tend in peacetime to become slightly diluted by these small battles that we engage in about pay and conditions. Now they're big to the people, but in the bigger scheme of things about saving lives and making lives better for people, we tend to probably lose sight of our purpose, our collective purpose. And I think if we can come together in the way that we've come together here, and like we in the centre have probably been more collaborative, have sought the advice, have sought the help because we've had to. People are happy to give us that advice, lots of different groups, and we work together. So in other words, to the general public, through the media, through the politicians who basically gauge whether we're good, bad or indifferent, they see a cohesive group working together for a common purpose. Yeah. And none of the spats that we've seen over the years, and in other words, the nurses taking chunks out of the doctors, everybody taking chunks out of the centre, all of that kind of thing going on. And I think the big lesson from this, I think, is that we have probably achieved a hell of a lot in terms of reputation, and we need to build on that, not go back to where we were. And people have often asked, how come the NHS could parade around at the start of the London Olympics? I think were there an Olympics here in 2 or 3 years' time, there's no reason why we couldn't be doing that if we continue along the path that we have been for the last 10 weeks. Yeah. Okay, those are the questions. There are 1 or 2 other ones there, but I think in the context of the time that we have, Caroline, we'll probably leave it there. Thanks to Paul, thanks to Philip.
Yeah.
And will I hand it back to you then?
Yes, thank you so much. Thank you so much to the panel. Thank you, Paul, for the summary. And what a rich and wonderful conversation that was. So we're well over time, but we have over 100 people checking in, and they haven't left us. So they're obviously interested to hear what you have to say. So I'd just like to thank you really from the bottom of my heart. I mean, it is such a good news story to hear about our health services, and we're all desperately proud of you, and we're desperately proud of our health service. And to say you are heroes without capes sounds a little bit glib, but the work that has happened, the confidence in the HSE, the confidence in your leadership has definitely peaked a scale, which is fantastic. And that's down to the hard work, diligence, calmness and directive leadership that you've all demonstrated. So I don't want to keep people for too late. So I just want to welcome everybody to next week's leadership lecture, which is with Professor Michael West. And he's going to talk about the courage of compassion in this crisis, leadership for now, leadership for the future in health and care, and build on lots of the reflections that Paul and Philip have experienced, and talk about how they actually work in terms of, you know, leadership in a crisis. And also additional supports are available through a series of video links and podcasts. Again, thank you to Professor Michael West, who's the Senior Visiting Fellow of the King's Fund and Professor of Organisational Psychology at Lancaster University. So my deepest gratitude to Paul Connors. Thank you so much for emceeing this event. It was really rich and lots of fantastic nuggets to take away. To Philip, and thank you again for working in partnership with us. It's been an amazing journey. We're enjoying it and look forward to more engagement with you, Philip. And finally, Paul, to you, your baptism of fire. You've demonstrated sterling leadership. We're terribly proud of you and your honest, relentless truthfulness in terms of your leadership style. So thank you all so much. And to our listeners, and if you want to put in topics for further conversations that matter, please email them to rcsileadership@rcsi.com. So all of the people who work relentlessly behind the scenes to make sure that this happens, thank you also. So on that note, I'll say good night and thank you so much to the panel. Thank you.
Thank you. Bye-bye.
Thank you.
Bye-bye. Thank you very much.
Thank you.